Hey all, welcome back to the Real Life Pharmacology Podcast. I'm your host, pharmacist Eric Christensen. Thank you so much for listening today. As always, go check out reallifepharmacology.com. I've got all these medications more in depth if you're looking for a specific review on a medication. The drugs today are going to be Fenofibrate, Doxazosin, Naproxen, Spironolactone. And the last one we'll cover is Memantine. So again, I've tackled all these medications individually in much longer, more detailed podcasts. So definitely go to reallifepharmacology.com, hit the podcast tab, and there should be a search bar on there where you can search a specific medication and go back and listen to them in more detail. So take advantage of that while you're at reallifepharmacology.com. Definitely go check out the top 200 medications PDF. It's a 31-page PDF on some of the most important things you're going to see in practice, as well as show up on your pharmacology and board exam. So definitely a no-brainer to have for any healthcare professional or any aspiring healthcare professional. All right, let's get into the medications today. We've got Fenofibrate. Brand name of this medication is Tricor. There's a bunch of different brand name medications for this. Tricor, Lofibra, Phenoglide. Those are probably three of the more common ones that I've seen utilized. It is a fibrate derivative. It's a medication used to lower cholesterol, and mechanistically, its classification is a PPAR agonist. So what does that mean? Fenofibrate is a peroxisome proliferator activated receptor alpha agonist. And that activation of PPAR alpha increases lipolysis and ultimately the elimination of triglyceride-rich particles from the plasma. Okay? So by eliminating triglyceride-rich particles naturally, what we're going to do is lower triglyceride levels. Okay, so that's what this medication is primarily used for. It's not used typically for patients who have elevated LDLs. We're going to go with statins to lower that type of cholesterol for patients. It's more so on managing triglycerides when patients are excessively high with those levels. Adverse effects, I would say most often is probably GI related, maybe some stomach upset, some cramping. Constipation is probably the most common one I've seen reported. I do want to emphasize that there is associated risk for rhabdomyolysis, kind of similar to statins. And naturally, that risk is likely increased when we add on a statin drug in combination with a medication like Fenofibrate. Now, one of the other fibroids, gemfibrozole, that risk probably tends to be higher for rhabdomyolysis than Fenofibrate with a statin. But I think it's important to recognize that that is a potential risk. From a monitoring standpoint, obviously, what we're going to be monitoring for is efficacy. We're going to be checking those triglyceride levels and making sure that the medication is actually working. That's one of the main reasons why we check those levels. We want to make sure that they're coming down. Because one of the issues with elevated triglycerides, elevated cholesterol maybe in general, it's generally asymptomatic. Patients don't know that they have elevated cholesterol until something, bad happens potentially. So with that said, checking those levels, we can help ensure that, patients are actually taking the medication and obviously responding to that medication as well. There are some important things with regard to dosage form. Fenofibrate is available as what's called micronized or non-micronized formulations, and they are not bioequivalent. So if you're dispensing these medications or administering these medications, they are not interchangeable. So I think that's an important thing to remember there with those different formulations. From a drug interaction standpoint, I don't worry a tremendous amount about drug interactions. Probably the statin thing is the most concerning thing that I look out for. Fenofibrate is reported to have some mild CYP2C9 inhibition. CYP2C9 plays an important role for a few drugs, but probably the most narrow therapeutic index drug that it could potentially play with is warfarin. Now, in that situation, we're just going to check an INR and make sure it's okay. So if you had patients started on fenofibrate, we know that it can impact the metabolism and breakdown and potentially raise concentrations of warfarin a little bit. We'd probably just check an INR, 3, 5, 7 days after starting that fenofibrate just to make sure that patients are okay. All right, next medication, number 92, is Doxazosin. Brand name of this medication is Cardura, and this is a non-selective alpha blocker. Historically, these agents, like Doxazosin, had been used to lower blood pressure. The outcomes data for this class of medication is not very robust, to say the least, as far as reducing heart attack and stroke and things of that nature. So these have really, really fallen out of favor for their use of hypertension. Couple that with the adverse effect profile of a medication like Doxazosin. It can cause dizziness, fainting type spells and symptoms. Priapism has been reported. Floppy iris syndrome has been reported as well in patients who are undergoing eye procedures like cataract surgery, for example. But really that dizziness, syncope type symptoms, adverse effects from this medication, that's one of the big reasons too, in addition to poor outcomes data, why these medications aren't used for hypertension very much anymore. Let's talk a little bit about that mechanistically. So by blocking alpha-1 receptors, it results in relaxation of smooth muscles around the vasculature. So it can kind of open up those vessels and reduce blood pressure. But it also can do that within the bladder and basically cause some relaxation there, which can help improve urinary flow. And a medication like Doxazosin, pretty much in practice, the only time I'm seeing this medication used is if you've got that dual indication. You've got a patient that could benefit from some blood pressure lowering effects, as well as some symptom relief from BPH as well. So that's probably the main situation that I see this medication utilized. As far as monitoring, what are we going to watch for, or monitor for? Obviously, we're looking for an improvement in urinary symptoms associated with BPH if we're using this medication. We're going to check that blood pressure to make sure it's not dropping too far and causing too much dizziness. So that's an important thing to think about there as well. Drug interaction standpoint, the significance of orthostatic hypotension and dropping blood pressure shouldn't be overlooked, particularly in patients where we're taking this for BPH and not necessarily for hypertension. That drop in blood pressure can be significant and certainly can be exacerbated by taking other alpha blockers like tamsulosin, which I have seen done in practice. Definitely not something I recommend or enjoy seeing. But also blood pressure lowering agents in general can obviously have that additive effect. And then PDE5 inhibitors are notorious for contributing to syncope, dizziness type symptoms as well. So your sildenafils, for example. All right, moving on, we've got Naproxen at number 93. Brand name of this medication is Aleve or Naproxen. This is a commonly used NSAID, so a non-selective COX inhibitor. It disrupts prostaglandin synthesis by inhibiting COX-1 and COX-2 enzymes, and ultimately this leads to anti-inflammatory, analgesic, and antipyretic effects. So as you could expect, we use Naproxen as an anti-inflammatory and pain-relieving type medication. Adverse effect profile. So first and foremost, with virtually all NSAIDs, we've got to worry about GI bleeding. Okay, and that's particularly true in patients taking multiple other medications that can increase the risk of bleed as well, and I'll discuss that a little bit in the drug interaction section. But adverse effects, GI upset, GI bleed risk, definitely two of the highest on the priority list there. Generally recommended to administer NSAIDs with food and or milk. I can kind of sometimes help prevent that stomach upset, or at least reduce that risk. Other things to think about from an adverse effect profile, we've got edema, so it can cause some fluid retention basically, and it can worsen heart failure and potentially ascites and those type of disease states. Hypertension, it can potentially increase blood pressure. That's something to think about. Most of these effects are dose dependent, so higher the dose, more likely you are to encounter these issues there. And then I do pay attention to renal function as well. If you've got a patient that's taking chronic NSAIDs, we've got to make sure that these aren't harming the kidney, because they can do that as well. So again, very, very important to make sure we monitor for that. Naproxen is mainly eliminated through the kidney, so it's important to think about the risks of nephrotoxicity going up, as well as the risk for drug concentrations to go up as that renal function declines. Monitoring parameters, obviously we're going to look at pain, fever, inflammation if that's what we're trying to treat, but also pay attention for any signs of bruising, bleeding, those type of things, because we can have some antiplatelet activity with a medication like Naproxen. In patients with cardiovascular disease, it's generally recommended to avoid NSAIDs if at all possible. If one is being utilized for pain and anti-inflammatory purposes, obviously limit duration, limit dose as much as we possibly can. Naproxen, in the scale of, riskiest from a cardiovascular to least risky, from that cardiovascular perspective, on that scale, Naproxen tends to be on the little bit safer side as far as cardiovascular risk goes. All right, drug interaction standpoint. So the two biggest things I think about are renal impairment. So patients who are on diuretics, ACE inhibitors, other nephrotoxic medications potentially, these can increase the risk of nephrotoxicity when used in combination with Naproxen. So definitely pay attention to that. In addition to that, I think about that interplay between NSAIDs potentially worsening edema in patients with heart failure who are probably on a diuretic, like furosemide, for example. So it can kind of counteract some of the effects of the diuretic there as well. And then lastly, with drug interactions, you've got to remember GI bleed risk, patients on anticoagulants, apixaban, warfarin, and so on, antiplatelet agents, your clopidogrel, your baby aspirin, prasugrel. These are all medications that could increase that GI bleed risk that's associated with NSAIDs. All right, moving on, we've got a diuretic. Speaking of diuretics, Spironolactone. Brand name of this medication is Aldactone, and it is classified as a potassium-sparing diuretic. Primary uses I see this medication are for heart failure, ascites, and also occasionally for resistant hypertension. Recall mechanistically, spironolactone antagonizes aldosterone receptors. So it competitively binds to aldosterone-dependent sodium-potassium exchange site in the distal convoluted tubule of the kidney. So ultimately leads to basically flushing out of sodium and water out through the urine and out of the body while retaining potassium. So that's kind of one unique difference between a potassium-sparing diuretic and a loop diuretic. Loop diuretics send potassium out with everything else, and potassium-sparing diuretics actually, the way they act, they cause the retention of potassium into the body. So we can naturally get hyperkalemia as one of the potential adverse effects. So rises in potassium levels can certainly happen with a medication like spironolactone. Hyponatremia is possible as well with spironolactone. Calcium and magnesium levels can also be low on account of spironolactone as well. So very, very important to monitor electrolytes when using a medication like spironolactone. Obviously, it can be used for resistant hypertension, so it's going to drop blood pressure. So that's something that we've definitely got to pay attention to there. In males, particularly gynecomastia, basically man boobs, the development of this can be a potential adverse effect, and obviously certainly distressing and problematic for some patients. So pay attention and educate about that as well. From a monitoring standpoint, obviously it depends upon the use. We're going to keep an eye on blood pressure, of course, and obviously fluid status as well if we're trying to run off fluid for patients. Potassium levels are going to be super, super important there as well. Other electrolytes should be a factor to consider as well. From a renal standpoint, you are going to want to monitor renal function. Again, whenever we send more fluid out of the body and send sodium out of the body with it, we can run into dehydration type situations. So got to make sure the kidney remains functioning well. Typically, if you've got a patient that has poor renal function to begin with, a creatinine of 2.5 or higher, it's probably a medication you're going to avoid in that situation. Again, we always got to weigh the risk versus the benefits. But if a patient's starting with a fairly significantly elevated creatinine already, or a high-end potassium already, spironolactone is probably a drug that we're going to want to avoid if at all possible there. All right, drug interaction standpoint. So thinking about this medication, the way it works, some of the issues, we can certainly increase the risk for nephrotoxicity when we use other medications that contribute to this issue. So NSAIDs, ACE inhibitors, more diuretics, which sometimes we use a loop diuretic with a potassium-sparing diuretic. But you got to keep in mind we got to monitor that renal function closely. So important to definitely do that. Medications that can raise potassium and have an additive effect on top of spironolactone. Potassium supplements. You'd be surprised how many times I've seen a potassium supplement on board and the patient's taking a potassium-sparing diuretic and their potassium levels are high and normal. Good time to reevaluate that potassium supplement and say, hey, do we really need this medication? Are we just making patients take another medication for no reason when the potassium levels are fine? So again, check those levels, pay attention to that. Other potassium-raising medications that are commonly used, ACEs, ARBs, trimethoprim, that's kind of a unique one as far as antibiotics go, that can raise potassium levels when used in combination with other potassium-elevating medications. Definitely one that could show up on your board exam for sure. A couple other interactions, digoxin elevations can happen potentially with spironolactone use, and then lithium concentrations can be elevated as well there. So good little pearls to remember for board exams there with regard to potassium levels, drugs that interact with spironolactone, of course. And speaking of board exams, if you're looking for study materials, go check out meded101.com/store, STORE. We've got BCPS, ambulatory care, NAPLEX, BCM-TMS, and many other materials that will help you prepare for your board exams. So go check that out. Support the sponsor, meded101.com/store. All right, wrapping up, we've got number 95, and that is Memantine. Brand name of this medication is Namenda. This is classified as an NMDA receptor antagonist. Its primary use is in the management of symptoms of Alzheimer's dementia. Mechanistically, it obviously goes with the classification. Memantine is a non-competitive N-methyl D-aspartate receptor antagonist, or NMDA for short, receptor antagonist. NMDA receptors are glutamate-gated ion channels, and Memantine blocks these receptors and prevents the overactive effect of glutamate, which is seen in some of the neurological conditions like Alzheimer's dementia. So, with that said, what are the adverse effects? As you could imagine, with a medication that works in the brain, we can see some CNS changes. Occasionally, you can have worsening confusion. You can have changes in mood, for example. Dizziness has certainly been reported as well. In general, Memantine is typically pretty well tolerated in my experience, but usually it's CNS changes that happen, if anything, there. This medication is eliminated primarily through the kidney, so pay attention to that renal function, and we may have to reduce dose based upon that kidney function. Of course, from a monitoring standpoint, we're going to want to see if we've had any improvement or stability in confusion and some of the Alzheimer's symptoms. That's primarily what we're going to monitor with this medication. There are a couple of dosage formulations. There's an immediate release and an extended release. The extended release has come down in price, so that's probably not too much of an issue anymore, but it may vary depending upon availability and suppliers and all that sort of thing too. But there is two different dosage formulations, and the dosing, I've blogged about this at meded101.com in the past. If you need to know how to convert Memantine IR to ER, I've got that on the website. But just know that the dosage forms are not identical. 5 milligrams of IR is not equal to 5 milligrams of extended release. Okay, so pay attention to that so we don't get those mixed up and give the patient an inappropriate dose. From a drug interaction standpoint, really not a ton to report with Memantine, so that's nice. Carbonic anhydrase inhibitors have been reported to interact potentially with Memantine. Acetazolamide is an example of that. But there again, not incredibly concerning. Not a lot of red flags with Memantine with regards to drug interactions. All right, well, that's going to wrap up the podcast for today. Do me a huge favor, support meded101.com/store. We've got Amazon books, case studies, drug interactions, pharmacist board certification, study materials, tons of info there that can definitely help you prepare for your board exam and or become a more educated, well-rounded healthcare professional when it comes to pharmacology. So go check out those resources at meded101.com/store. And obviously that helps directly support this podcast. If you'd kindly leave a rating review on iTunes or wherever you're listening, I'd greatly appreciate that. If you got comments, questions, suggestions, mededucation101@gmail.com, or you can connect with me on LinkedIn, Eric Christensen, PharmD, BCPS, BCGP. All right, well, I'm going to sign off for today. Thank you so much for listening. Take care and have a great rest of your day.